Hello everyone, and welcome to the Department of Ophthalmology. My name is Dr. Vince Cabahug, and in this lecture, I will be sharing with you the most common ophthalmology cases I have encountered during my training, and hopefully this will help you as you go along with your Ophtha rotation, be it as a resident, intern, or a clerk. To start off, here are some useful source materials. I do not own the images you will later see in this lecture. In fact, you could read them up in most of the sources here. I personally recommend the Will's Eye Manual as you go about with your daily duties. The Kansky Clinical Ophthalmology has a lot of good photos in it, and for the more dedicated reader or those planning on pursuing an ophthalmology residency, you can refer to the AAO series. With all that said, I would like also to acknowledge my former consultants and seniors whom I trained under, as I will also share some very informative material I learned from them. So let's get started. Here is the list of the most common eye conditions referred to the ER during my residency training at the St. Luke's Medical Center Eye Institute. These are rough estimates, and take note, the frequencies may vary depending on your institution. Government hospitals tend to accommodate a higher volume of trauma cases. I can almost guarantee that you will encounter patients complaining any of the top 10 conditions listed here. As you can see, the most common is still viral conjunctivitis, or sore eyes. And at number 7, sometimes the patient just has a normal eye exam, and the patient just needs to be reassured. And in some other ER cases, which are not that common, some are actually life-threatening and some are urgent. And you also need to know how to manage these cases, such as acute angle closure glaucoma or a chemical burn perhaps. So let's imagine you are on duty tonight, and the ER med, or say the nurse, will call you. The first step is to always rule out the true ocular emergencies: chemical injury, central retinal artery occlusion, and an acute angle closure glaucoma, which is also an urgent case. Okay, so I will now show you a series of cases. I will provide a short history and give you some pertinent findings. You may pause the video and try to think how you might manage these cases. Case 1. We have a 7-year-old male who's complaining of an upper respiratory tract infection and is complaining of eyelid swelling and as well as some redness at the left eye. The visual acuity is 20/20. What else would you look for in this eye exam? So in this case, you need to watch out for some chemosis, an RAPD, limitation in extraocular movement, pain in eye movement, and the presence of proptosis. And if none of those were present, then we could diagnose this patient with preseptal cellulitis. So this is an infection, and if there's more posterior involvement, in which case the optic nerve or even the extraocular muscles get involved, then we would have an orbital cellulitis. So those findings that you need to watch out for is what assures us that the infection has not spread more posteriorly. You need to treat this patient and start with antibiotics. So you could give oral cephalexin, coamoxiclav, or cloxacillin. Also do warm compress, and you need to watch out for blurring of vision, proptosis, limitation in eye movement, and diplopia. You can follow up this patient after a week. And you have to take note, if there is no improvement in antibiotics, then you might need to admit this patient, most especially if it's a pediatric patient, in which case you might need to be more aggressive in your antibiotic therapy. Case 2. A 40-year-old female complaining of left upper lid swelling. Pain and redness are also present. So please refer to the photo. What do you think is this case? This is a case of an internal hordeolum on the left eye. So plan of management, you just need to do warm compress 3 times a day with light massage. Optionally, you may start an antibiotic such as cephalexin, coamoxiclub, tobradex with erythromycin ointment, and you may follow up after a week. The patient may also experience pain, so just offer some pain medications such as mefenamic acid. In external hordeolum, or otherwise known as sty, the infection is located more externally, usually an eyelash. In this case, you just need to epilate that eyelash. Still do warm compress, and optionally give an antibiotic. Case 3. A 30-year-old male was complaining of eye pain and said that he was poked in the eye while playing basketball. There is some discomfort when blinking and tearing. In the eye exam, there is dye uptake. So what is this case? So if you thought this was a corneal abrasion, then you got that right. And other pertinent findings is that there is usually a history of trauma, contact lens wear, and the patient will complain of foreign body sensation, tearing, and cannot open his eyes. Notably, this is relieved with alkane eye drops. For our plan of management, you need to give this patient some antibiotic eye drops. Taking note that different antibiotics may be needed if this was associated with a fingernail trauma, plant matter, or an associated contact lens wearer. For larger corneal abrasions, it can be very painful, so you may offer to apply a bandage contact lens. You follow up this patient after 3 days to see if there is any improvement, or if there is no infection present. Case 4. A 56-year-old female with a 3-day history of foreign body sensation, watery discharge, and red eye redness. Is this conjunctivitis? If yes, what type is it? So the key findings here is a red eye and discharge. With that, you also need to think of other differentials for red eye. Remember to always stain. Take note of the key questions: the onset and duration, the characteristic of discharge, if there was any trauma or if the patient was wearing contact lens wear, if there is prominent itching, some exposure or systemic complaints, or the use of topical medications. With that in mind, we can classify this type of conjunctivitis, whether it's hyperacute, acute, chronic, or recurrent, whether it's infectious or non-infectious. And again, these will help us categorize the type of conjunctivitis and be able to plan our management. So in this busy slide, you may need to pause the video so you could study and see for yourself how different clues will help you determine the type of conjunctivitis. Here, in terms of onset, hyperacute is when it occurs in 1 to 2 days, and this is usually due to gonorrhea, a chemical burn, or even trauma. For longer cases, like chronic cases more than 14 days, it might be due to chlamydia, tuberculosis, or a moraxella. Sometimes an allergic case or an allergic conjunctivitis may also take a chronic form. Recurrent cases can either be an allergy or staphylococcus infection or vernal keratoconjunctivitis. So the onset gives you a clue on the terms of the etiology. And next we have the type of discharge. So you need to take note if it is serous, if it's purulent, or a combination of both, and this will also guide you on the probable diagnosis. For gonorrhea, it's usually very purulent. Mucopurulent, you have Haemophilus, Staph, Strep, even chlamydia and moraxella. For mucoid or stringy or ropey discharge, you have allergic. Allergic can also be serous and watery, so as adenovirus. So you just need to pause the video if you need, so that you could study this slide. And finally, some other clues in which you could take note during the eye exam. There are some cases that present with more papillae. Some cases have more prominent follicles. Sometimes you might see some membranes, granuloma, preauricular nodes, or even lid and skin lesions. And that will help you narrow your diagnosis. Feel free to pause the video again so you could take time to analyze and digest the load full of information here. Okay, so what is the difference between a follicle and a papillae? And here are some two pictures that will help you differentiate the two. Papillae usually are fibrovascular, and follicles are lymphoid. So if we go back to our case, what type of conjunctivitis is it? So this is a 3-day history of conjunctivitis, mostly watery discharge. And of course, the most common will most probably be an acute viral conjunctivitis. It's very self-limiting, and it will usually resolve within 3 days. So you need to resist the temptation to give antibiotics. So you just need to reassure the patient. You may offer artificial tears, cold compress, advise proper eye and hand hygiene. Also need to avoid close contact and follow up this patient and see if there's any improvement. There you will decide if antibiotics may be needed. If you recall the list a while ago, what was the most common eye condition referred to the ER? And yes, it's still viral conjunctivitis. So when you do decide to prescribe some artificial tears, there are two types, those with preservatives and those without. Ideally, if there is no preservatives or a non-preserved eye drops, you could actually apply it as often as every hour. While in eye drops that have preservatives, just limit it to 4 times a day. Here is a list of the different types of artificial tears. And now, should you give topical steroids? So in some cases, this might be needed in those eyes with that has a presence of membranes or pseudomembranes, sight-threatening subepithelial infiltrates. But again, you need to individualize treatment because giving steroids may hasten the resolution of symptoms, but it will prolong the infectious period. Here are some examples of topical steroids. Okay, so that was viral conjunctivitis. What about allergic conjunctivitis? So the most prominent symptom here is itching. The patient may also have a history of allergy. The discharge is watery, sometimes mucoid, and it may involve the eyelids. The plan of management of allergic is similar in that you just need to give artificial tears, but you may add an anti-allergy eye drop such as olopatadine or Patanol 2 times a day for 2 weeks. Steroids is optional for moderate to severe cases. Here are some examples of topical anti-allergies. So if it is not allergic or viral, you might be dealing a case of bacterial conjunctivitis. And in this case, there's usually papillae. It can be acute or subacute. And the discharge is usually purulent. So among the possible etiologies are Staphylococcus, Streptococcus, Haemophilus, and Moraxella. For gonorrhea and chlamydia, there is usually a sexual history, and it's hyperpurulent. The plan of management for any bacterial conjunctivitis is always to treat the infection. So you need to give the appropriate antibiotic depending on the possible etiology. Like in gonorrhea, you might need to give a ceftriaxone and also an oral azithromycin for a concomitant chlamydial infection. Again, you need to treat the partner for this type of case. Case 5. A 63-year-old male who is hypertensive and diabetic complained of sudden eye redness, but there is no pain, no blurring of vision. And you can see in the photo here, it does look problematic. What would you ask? So you could ask if there was any history of trauma. Otherwise, if this was just a spontaneous event, then this may be a subconjunctival hemorrhage. And here are some other pictures. It looks bad, but it is very much okay and it will resolve in its own. You just need to advise a cold compress in the first 24 hours and then warm compress. There's no need for any take-home medications. They may enlarge and may take weeks to resolve. For those with a history of hypertension, then the patient may need to control their hypertension for that matter. Case 6. A 40-year-old female with mild discomfort in the right eye. There is some redness and no other symptoms. You can see here in the photo. And a key finding is that it blanches, especially with phenylephrine eye drops. So what is this case? So if you thought it was Episcleritis, then you got that right. And in that case, it's usually self-limiting. You just give some artificial tears or a mild steroid like lotoprednol. Follow up with signs of scleritis. So in scleritis, it's a much more deeper form of inflammation compared to episcleritis. And in scleritis, it does not blanch when you apply phenylephrine eye drops. Case 7. A 60-year-old female complaining of sudden onset blurring of vision. She experienced some halos around lights, some dull pain, and nausea and vomiting. When you check the patient's eyes, you notice that there is a hazy cornea, some conjunctival hyperemia, and non-reactive pupils. So what is this case? Now the Ophtha resident came by and did some further examination and noticed that there is a shallow anterior chamber depth, and more importantly, a high intraocular pressure. When he did the gonioscopy, noticed closed angles. So does that ring a bell? So we're dealing with an acute angle closure glaucoma. And just to define some terms, estimating the anterior chamber depth, we use the Van Herrick method. And I show you here, the Ophtha resident will use the slit lamp for this. In angle closure glaucoma, there's usually a pupillary block mechanism in which the pupils come in contact with the lens, and this obstructs the angle, as you can see here in the diagram. Now, you might not be able to perform gonioscopy, but here's a photo on what the ophthalmology resident might see. But the picture above is a normal angle that is usually open, and there are some structures that you'll be able to appreciate. The photo below is a closed angle. The resident may also perform a maneuver called indentation gonioscopy, and this is an attempt to see if the angles can still be opened. In acute angle closure glaucoma, the angles may be closed due to some synechia, and the angles will remain closed even if performing this maneuver. So how do we treat this patient? So this is an urgent case, and you need to break the attack. So you need to lower the pressure, and some of the meds you can give is timolol, brimonidine, and acetazolamide. Taking note that these medications also have some side effects. Now, you may also give a 20% mannitol if you really need to lower the pressure, and this is how the dosage is shown here. And after giving those meds, you need to check the IOP every hour, starting from the time ER finished giving the meds. So you need to bring the IOP down to at least the low 20s. You need to write down all those readings and also check the gonioscopy if there is an improvement. The resident may call the consultant to get an immediate laser iridotomy done. So that is the definitive treatment for this case, in which laser is applied to burst a hole in the iris so that there will be a patent flow of aqueous humor. So this is our assessment again, acute angle closure glaucoma, and our plan of action is shown here. Case 8. A 50-year-old male who is a contact lens wearer. Now is complaining of a 4-day history of eye pain, photophobia, and blurring of vision. There was no history of trauma. So some pertinent eye findings: there is dye uptake, there is cells and flares, and there's no hypopion. And if you look closely at the cornea, there seems to be some haziness or some infiltrates. So what is this case? Now, before arriving at a diagnosis, some further questions that needs to be asked is about the onset, associated trauma, the use of contact lens, and presence of ocular disease. And this might give us an idea of the possible etiologic agent for this infection, as stated here. After all gathering the information needed, this is a case of a microbial keratitis. So a lot of possible infections can be associated with it. So you need to scrape, do a gram stain, and culture and sensitivity. If the lesion is larger than 2 millimeters, if it involves the deep stroma, if the visual axis is involved, or there's an atypical presentation. Lastly, if there's also no response to broad spectrum antibiotics. So going back to our patient, we can give the impression of a central microbial keratitis, probably bacterial, and we will now start with broad spectrum antibiotics such as moxifloxacin eye drops. You may give atropine eye drops, and of course, no contact lens wear for now. Then you need to follow up the patient to see if there is any response. Hopefully there is. Okay, let's move on to another case. And this time it's a chemical injury. The emergency department called you that there is a patient that was exposed to muriatic acid. What's the first thing you ask? You say, "Did you irrigate?" And they said no. So what do you say? "What are you waiting for? Please irrigate." And this needs to be done immediately because chemical injury is another ocular emergency. While doing first aid measures, you could always acquire the history as you perform the irrigation. Any fluid will do, be it NSS, LRS, or even tap water. Again, the important thing here is to bring the pH to neutral. So chemicals can either be alkaline or acidic. It's usually the alkaline ones that are more problematic and more pathologic. If you look at the photo, you can see how irrigation is done, and usually a lid speculum is needed to open the eyes after anesthetizing it. And then the irrigation follows. After successfully doing those first aid measures, you don't forget that you also need to take the visual acuity, perform a thorough slit lamp examination, and an important thing here is to check the intraocular pressure, do a dye staining, check for any sloughing of the epithelium, some chemosis, and any anterior chamber reaction. You might need to debride any necrotic tissue, and also sweep the fornices, for there might be any trace foreign bodies that is causing some chemical injury. The table below is a classification or the grading of ocular alkali burns. It's depending on how severe it is, but this is more for the ophthalmology residents. In a nutshell, mild cases usually just have a epithelial defect, while in the more severe cases, there is already ischemia and the cornea becomes really opaque. Now here's a summary of your plan of management for any chemical injury. You provide topical artificial tears, steroids if there is any AC reaction, prophylactic antibiotics or ointment, some atropine drops. You may give timolol if there is an elevated IOP, and may place the patient on a bandaged contact lens. Of course, you need to follow up this patient and see if there is any improvement, like in any other case. Okay, so we covered most of the top 10 common eye conditions, but it's not any excuse that you shouldn't study other uncommon eye conditions. So what are other important cases you need to know? So here's one: central retinal artery occlusion, or CRAO. A patient will complain of sudden painless blurring of vision Vision is usually counting fingers or even hand movement, and the very famous cherry red spot, which doesn't really look cherry in this photo. And this is a true ocular emergency. So what should you do first? You need to call the retina team. There is a golden period of 90 to 120 minutes, or else there will be irreversible visual loss. These measures are sometimes anecdotal, but it's usually advised to perform ocular massage, anterior chamber paracentesis, acetazolamide and timolol or brimodin to lower the IOP, and could even tell the patient to do brown bagging. It's when they breathe through a brown bag. Again, none of these measures seem to be proven, but it's what's usually advised. After initiating your management, you need to take note that CRAO might be a complication of a systemic disease, such as hypertension, or in the Western population, it might be due to giant cell arteritis. So essentially, there is an ischemic problem occurring, and CRAO is a complication of that. So you might need to refer to the internal medicine team to work this patient up. So here's another case. Just look at the picture. This patient is complaining of periorbital pain, and more prominently in the photo, you could appreciate some vesicles and pustules. The patient also has some periorbital edema. So what is this case? To help in our diagnosis, you need to perform a complete eye exam. And here's some key findings that you might appreciate. You could see the eyelid vesicles, some follicular conjunctivitis, and in the top blue photo, there's actually a slit lamp but under a cobalt blue filter. You could see those branching patterns, so those are pseudodendrites. So very pathognomonic for this case. In the photo below, some nummular corneal infiltrates, and the patient seems to have a high IOP. So with those findings, we assess this patient to have herpes zoster ophthalmicus. Our plan of management is to give antiviral drugs, as here. You may also want to give the patient some topical preservative-free artificial tears. Now, take note of the meds. So there are different dosing depending on which antivirals you want to give. And if there is associated elevation of the intraocular pressure, then just give timolol or brimodin. Other than eye findings, if this patient is systemically ill, or there is orbital or cranial nerve, or even optic nerve involvement, then you need to advise admission. Call the consultant on deck, and you might need to up your antivirals, just a cyclovir. You might need to give them intravenously. Here's another common case, a corneal foreign body. So you treat this as a corneal abrasion. So just go back to the video about corneal abrasion, and that's how you treat it. But of course, since there's a foreign body, you also need to remove that. So the ophthalmology resident will perform that, and you may want to observe. Take special precaution because sometimes the foreign body is behind the upper lid. In that case, you need to invert it. Now, if you're in a government hospital, here's one case that you will definitely see, and say it's already 12 midnight, and you get a call that there was a trauma case. And you see here, it's an eyelid laceration. So what do? Of course, get the visual acuity and answer this question: does it involve the margin, or the eyelid margin, or the canaliculus? If yes, then you might need to refer this to the oculoplastics team for help. Anyway, if not, then you need to repair this. So you need to stay up late and suture that laceration. Like any minor case, you still need to secure the consent. And some general guidelines: always clean, irrigate, and debride any dirty or necrotic tissue. When you repair, take note if how deep you plan to engage the tissues. If deep, you use Vicryl 6O. For the skin, you may use simple interrupted ethylene 6O. And well, if it's not too big of a laceration, then Steri-Strips or a histoacryl glue might be appropriate. Again, refer if you're not sure. If it's a pedia case, of course, you need to check if the patient is cooperative. In those cases that is very young and very restless, then this might need some general anesthesia. If you finish that, if you finish repairing that laceration, then don't forget to apply some antibiotics as a take-home medication. Pain meds can be optional. And yes, follow up the patient once if there's any improvement. Traumatic hyphema. Of course, there is a history of trauma. But what usually causes this is blunt trauma or sometimes an elbow from playing basketball. When doing the eye exam, you will note that this pain will not be relieved with alkane eye drops. The patient will complain of blurry vision. There might be a hazy anterior chamber, and the hyphema may range from being a microhyphema or an 8-ball hyphema covering the whole eyeball. IOP may be increased. For this case, here's a general treatment guideline. So you need to advise some complete bed rest and maybe a high back rest. You provide atropine eye drops, some steroids like Pred Forte. You can combine this with an antibiotic if appropriate. Tranexamic acid, timolol, and paracetamol. An eye shield with view. What that means is you could check the eye so that you'll be able to recognize if there is rebleeding. So you just need to observe this patient and follow up as the blood would regress. Again, a history of trauma, but this time the bones are involved. So we have an orbital trauma. And what signs would you watch out for? So you watch out for enophthalmos, crepitus on the orbital rim during palpation, loss of sensation in the cheek, point tenderness, and most importantly, if there is any restriction in eye movement. Well, this may be due to the swelling. Again, you have to make sure there is no globe perforation. Also check the visual acuity. And once you're done with all those measures, then a CT scan might be appropriate to just prognosticate and see the involvement of any possible fracture. What walls are involved? Usually it's the orbital floor. Most of the time, orbital floor fractures can be observed, but there are those cases where surgery might be indicated. And it's when enophthalmos is greater than 2 millimeters. If there's already diplopia that's persistent in primary gaze, or the CT scan findings show an involvement of 50% of the floor, or those cases where there's an ocular muscle being impinged. If that's the case, then you need to schedule for surgery. Now, this is the last case, which you might think it's a surprise, but this can happen. So, super glue or any type of glue that got stuck in the eyes. So, of course, don't panic. You just need gentle traction on the eyelids. Apply gentle traction, and you might want to cut some lashes. If it's in the cornea, then just remove it with forceps. And of course, remember to apply some anesthesia before performing this. And alternatively, you could apply a warm compress, and that would probably dissolve the glue. So that's the end of this lecture. If you are watching this on YouTube, here's a pro tip. If you want to review it again, watch it at 1.5x speed to save some time. I hope you learned something about ophthalmology today. If you did, put a thumbs up, and thank you for your kind attention.